Live, Blake?
We sure are.
Okay, then I better start talking and making sense. Good afternoon, everyone, and welcome to the September edition of the NRTRC monthly webinar. I'm Bob Wolverton, Program Director for NRTRC, and I want to welcome you and thank you for joining us. If you have colleagues who want to see the presentation for today, Blake will be recording it and we'll have it up on our website as soon as possible, within the next day or so usually. I just want to remind you that our next webinar will be on remote patient monitoring with Christian McCarran. That'll be October 27th, and we certainly invite you to join us there. And I also want to remind you of our 6th annual NRTRC Telemedicine Conference in Seattle this year. It'll be April 10th through 12th. And actually, today's presenter, Allison, and next month's presenter, Christy, both presented at the conference last year and got really high marks. So we're looking forward to sharing information with you and seeing you at the next conference. Let's see. Oh, and yeah, one last quick thing. Blake will put a survey up at the end of the session for you to respond to what you thought about today's webinar, and equally as importantly, to let us know what you'd like to see in a future webinar, because we're here to give you the information and education you need. So let me start by introducing our presenter today. Dr. Allison Lindauer is Assistant Professor of Neurology at Oregon Health Science University's Layton Aging and Alzheimer's Disease Center. She's a co-primary investigator and manager for the ACT-ON program, which I believe she'll be talking about today. And she has more than 18 years' experience as a nurse practitioner caring for elders and persons with dementia. She's nationally board certified as both a family and gerontological nurse practitioner and is credentialed to provide telemedicine care. Dr. Lindauer's research focuses on telemedicine care for persons with dementia and dementia caregiving, and her work is published in national and peer-reviewed journals. And if you have questions for Dr. Lindauer during today's presentation, there's a Q&A pod you can use to type the questions in, and we'll get to them as quickly as we can when we see them coming up. So without further ado, Allison, take it away. Allison, I believe you're muted. You might want to, there you go.
Okay. Just want to make sure you can see the slides okay?
Yes, we can.
Thanks, Bob. Well, thank you so much for the invitation. Indeed, I did present our early work at the conference last year, and it was a very lively conference, and I had a very nice time. And I'm delighted to report the final findings of our study done here at the Layton Center at OHSU, Oregon Health and Sciences University. I'd like to start just giving you a little bit of background. Our center here, the Layton Aging and Alzheimer's Disease Center, is one of 30 Alzheimer's disease research sites in the nation, and the only one of its kind in Oregon. As such, we are funded by the NIA and conduct a variety of research programs, both to define and explain what Alzheimer's is, to find treatments, and to identify ways to help families manage the challenges of the disease. Today, I would like to talk a little bit about our program, Alzheimer's Care via Telemedicine for Oregon, ACT-ON, and just want to point out that this study was funded by the Oregon Health Authority and administered through the Oregon Office of Rural Health. And please type in questions as we go. So many of you, I'm sure, can appreciate this problem. If you're a caregiver for a person who lives in a remote area, how do you get the care that you need? And for those of you who are not familiar with dementia, dementia is actually an umbrella term that defines the problems with thinking or cognition that affects daily function. And there are many types of dementia. The most common type of dementia is Alzheimer's disease. And that's what this study focused on, is Alzheimer's disease. Alzheimer's disease is characterized by gradual, slow, progressive memory loss, but also behavioral changes. So over time, we see people who do lose their memory, but also their personalities change. They may become more anxious, more apathetic, more depressed, and oftentimes it's accompanied by behavioral changes. So things like wandering, pacing, asking questions over and over, getting irritable very easily, or, quote, blowing up easily. What the research shows us is it's actually the behavioral changes that cause the most amount of stress for caregivers. So if you would imagine for a moment that you're a caregiver and you live in Burns, Oregon, and you care for somebody with moderate Alzheimer's disease who actually does fairly well when she's in her own environment and with the people she knows and on a routine schedule. When the schedule changes or the people in her life change, she becomes agitated and paces and asks the same question over and over. Your job is to get her to our center in Portland, which is about a 5-hour drive over mountainous passes. You complete the drive, you get to your hotel room, meet with staff that don't understand your situation, sleep in a hard bed, and don't have great food. And then at 5 in the morning, your care recipient wakes up and starts saying, I want to go home, and repeats the question about, every 5 minutes or so. You get up, get her changed, get breakfast, drive over to our high-rise, come up to the 8th floor, sit down. Neither one of you have had a good night's sleep, and one of us walks in and says, it's now time for your memory test. It doesn't seem really fair to put people who already have a neurocognitive disorder under this amount of stress to test their cognition. And so with that in mind, our center decided to develop a telemedicine program so that we could meet the needs of families both at distance and, in fact, even those close by. So for some families, symptoms such as delusions or anxiety or even apathy can make it just very difficult to get into the clinic, even if they live 5 minutes away. In order to develop our telemedicine program, we realized that we had to establish whether the measures we use in telemedicine are indeed reliable. So we developed a program in phase 1, which I'll be talking mostly about today, but I will also discuss phase 2. We decided that we needed to establish the reliability of measures commonly used in dementia evaluations. We know that people with dementia are often evaluated via telemedicine, but we don't know how reliable those measures are. Our aim was then to take those measures that we established the reliability of and move into assessing the feasibility of doing a standard clinic visit for persons with dementia when done via telemedicine. So to describe phase 1 in a little more detail, numerous studies have been done that assess the reliability of measures of dementia and cognitive function, and they tested these across the telemedicine platform. These studies seem to have started in the early 1990s with Ball's work, and over the years there have been at least 9 other studies. However, the majority of these studies were done with a test called the Mini Mental State Exam, also known as the MMSE. The MMSE has been around since the 1970s and is often the most frequent test we use to assess people with cognitive function. However, it's what we call a blunt instrument. It's not a very challenging test, and it doesn't give us very much information on the degree of cognitive impairment with our patients. In the early 2000s, Nasruddin developed what's called the Montreal Cognitive Assessment, which we find to be much more sensitive to cognitive change and helps us assess and understand various domains of cognitive impairment. So, for example, somebody may have their short-term memory may be fairly okay, but their visual function may be lacking, and the MOCA would test that. The Montreal Cognitive Test, also known as the MOCA, has only been tested once via telemedicine, and that was through Abdullahi's work in 2014. Unfortunately, or fortunately, I guess as the case may be, this study only looked at people with movement disorders. It didn't evaluate if it's reliable over the telemedicine platform when used with people with Alzheimer's disease or other dementias. In addition, we have no measures that I could identify that assess the reliability of measures of caregiver health. So, for example, strain or grief. And if any of you know of any studies that do assess these measures of reliability via telemedicine, I'd love to hear from you because I have not been able to identify any. And that's quite important. The reason all of this is important, as you probably know, is that Alzheimer's disease and related dementias affects 1 in 9 adults over the age of 65. That's 5.5 million people in the United States. Caring for these people are millions of caregivers who provide provide care that's worth billions of dollars. Alzheimer's disease and related dementias is the most expensive disease in the United States these days, more so than heart disease and cancer. So reaching out to people via telemedicine to understand their cognitive function, as well as assessing the health of the caregivers, we felt would not only help ease the strain of caring and of assessment by bringing the care to the home, but would also help reduce costs. Any questions so far? Okay. So again, in phase 1, what we aim to do is assess the intersite correlation of assessment measures for persons with Alzheimer's disease, as well as their caregivers. For this study, we recruited 28 caregivers and 28 people with Alzheimer's disease and their caregivers. And we did 2 identical batteries of tests. We did 1 battery in the clinic and 1 via direct-to-home telemedicine. And these 2 tests were about 2 weeks apart. And participants were randomized to receive either the in-clinic or the telemedicine initial visit first. So half of the patients, we hooked up with them and did the telemedicine battery of tests first, and then had them come into the clinic to do the clinic tests. The other half did the clinic test first, and then we met them on telemedicine to do the battery test. This was an IRB-approved study through the OHSU, and everybody that participated, the caregivers and the care recipients, signed consents. We had 2 raters, or actually we had 3. One rater had to leave, but essentially we had 2 raters. One person did half of the in-office, in-clinic assessment, and then switched to do the telemedicine visits for the second half of the sample. We were trying to avoid inter-rater confusion on the reliability scores. So these are the measures that we used for the participants in our study. For persons with Alzheimer's disease, which is abbreviated as AD, we assess them with the Montreal Cognitive Assessment. That's the test I was telling you about earlier, in which there was only 1 reliability study when used with telemedicine. We also assess the reliability of the Clinical Dementia Rating Scale, which we call the CDR, and the CDR is used as a survey to ask the caregiver about the care recipient. So we ask them questions like, does your care recipient or family member have a memory problem? Does your family member know how often does your family member know the date, the time? Can you send your family, can your family remember a short list of items such as a shopping list? And then the CDR continues to ask questions along those lines, and including questions about, can your care recipient feed his or herself, and do they need help with bathing and toileting? The next measure of cognitive function was the Revised Memory and Behavior Problem Checklist, also known as the RMBPC. The RMBPC was developed in the 1990s and is the second most common measure of caregiver stress when used in studies in the United States. The RMBPC asks families if a behavior occurs. That's in the top section of your slide where it says number of behaviors. And then the second part of the RMBPC asks how much those behaviors upset the caregivers. So it's a two-pronged measure within one measure. So for the persons with dementia, we simply ask the items if a behavior occurs. So that could be wandering, asking the same question over and over, talking about feeling worthless, pacing, hurting other people, hurting themselves, those kinds of questions. The last measure we used was the geriatric depression screen, which is a 16-item yes/no questionnaire asking the people with Alzheimer's disease if they have certain symptoms like an example of the question was, I feel happy most of the time, and the answer would be yes or no. So for the people with Alzheimer's disease, we assess them specifically with the Montreal Cognitive Assessment and the Geriatric Depression Scale. We assess them indirectly with asking their caregivers about their clinical dementia on the rating scale, and we ask their caregivers about whether or not they have behavior problems. The second set of measures were for the caregivers. For the caregivers, we asked them about burden with the Zarit Burden interview, which I refer to as the ZBI. Zarit Burden interview is the most common interview used to assess caregiver burden. We also asked them about their grief. We know that caregivers who experience grief as they witness the losses that occur with Alzheimer's disease, that this grief increases their feelings of being burdened, and it also can be confused with depression. So if we can identify who's grieving, we can start to make interventions that can help with the grief experience and recognize that it's not necessarily burden or depression, but is actually grief. And we measure grief with the Marwick-Muser Caregiver Grief Index. This was developed in the early 2000s as well. And it has a statement that the caregivers tell us how much they agree with the statement. So for example, one of the statements is, it hurts to put him to bed at night and know that he is gone, in quotes, the gone's in quotes. And then they tell us how much they agree or disagree with that statement. And then again, for the caregivers, we are coming back to the RMBPC. We've asked them, how often do you have a behavior for the caregivers? But in this section, we ask them how much it bothers them. Not at all, a little, quite a bit. You get the idea. So I want to talk briefly again about the MOCA. Again, it's a 30-point cognitive assessment, and it measures a variety of functions that make up our cognitive abilities. So again, the visual spatial abilities, executive function. So executive function is how well we make decisions. Verbal learning and memory, attention, concentration, language, and orientation. So for the in-clinic visit, we simply verbally administer the test. Similar to how we would do it on any regular clinic day. And we followed the protocol, the script that comes with the MOCA test. For the people for the participants, when they were going to have their telemedicine visit, shortly before the telemedicine visit, we mailed them the visual, spatial, and executive sections to the families, so that when we had the telemedicine session, they would have the paper and pencil test in front of them. So, for example, one item that we asked was we asked people to do it to draw a trail from numbers to letters. We asked people to draw a cube, and we asked people to draw a clock. Only those 3 sections were mailed to caregivers, and we asked them to keep those aside until the telemedicine visit, so not to look at them prior to the telemedicine visit. During the telemedicine visit, once we got on the screen with the person with Alzheimer's disease, we would start the MOCA test by asking them to open the envelope and pull out the paper, and we would talk to them about how to do those 3 top puzzles. So this isn't typically how it's done, but it was the best way we could figure out how to do it via telemedicine. They did the puzzle, so for example, the trail, and then they would hold the picture up to the camera for us to look at and to score. Of the 28 participants, we only had 1 scoring error. And we had 1 page for each item. In the MOCA done in the clinic, it's all on 1 page, so there's a lot of information that people see. We didn't want to do that for the telemedicine visits because we wanted to make sure that there wasn't that distraction. The second part of the MOCA test involves the visual spatial function, where we ask people to identify animals that are commonly recognized. And we shared that picture with the participants on the screen. So you'll see here, this is a picture of me, and I'm the patient, and I'm supposed to be looking on my screen. I have the animals, and I am supposed to tell my rater the names of those animals. And my rater, as you can tell, theoretically would be my colleague Adri Seeley up in the screen there. But this is a screenshot of what a typical participant would see. Another modification that we made on the MOCA test was, in the MOCA test, we have, in real life, so to speak, we read a long list of letters. And we ask people to tap their leg every time, or tap the table every time they hear the letter A. When we used the telemedicine, we were a little bit worried that we wouldn't be able to see or hear the tapping. So we asked people to clap instead, and we asked them to hold their hands up to the camera so we could make sure we could see the clap. I'm not sure if you can see my pointer, but at the top of my computer here is the the string of letters, and we kept it up near the camera so that we could give the impression that we were looking at them as we were reading the string of letters. So we would read the letters, and every time we said the letter A, they would clap. All right. The other test that we did, I described earlier. And we measured the reliability by using test-retest techniques and measuring the interclass correlation coefficient for continuous variables, and the kappa statistic for categorical variables. So just to reiterate, for people with Alzheimer's disease, via telemedicine, they got these measures. And again, the caregivers would report on the CDR and the RMBPC, and they would also get these measures in the clinic. So the only thing that was really different between these 2 sites was the telemedicine milieu. Similarly for the caregivers. So I just want to review our results with you. We had 28 participants, so 28 people with Alzheimer's disease and 28 caregivers. 61% of the caregivers were female, and of interest, 61% of the persons with Alzheimer's disease were female. This is not a mistake. Alzheimer's disease is more common in women, and caregivers more commonly tend to be women. So 2/3 of Alzheimer's cases are in women, and 2/3 of the caregivers are women, and 2/3 of the people with Alzheimer's disease are women. But it was interesting that they matched up in our study. So for example, we would have spousal dyads, so a husband and wife, but we also had several mother-daughter dyads, and then I believe one women partner dyad. The age range was quite broad. You'll see the 38 to 79 for the caregivers, and for the persons with Alzheimer's disease, you'll see the range was quite broad, 51 to 96. The reason for this fairly large spread of age is because at our center, we often offer people with Alzheimer's disease in our clinic to participate in research. Unfortunately, many of the drug studies are not available to people younger than age 60 or 65. We did have, as you can see on the persons with AD, some people that came to our center with young onset dementia, and they were very eager to participate in any kind of research, and they were wonderful in signing up for our studies. But it just indicates how much we need research, and we need research opportunities for young onset Alzheimer's disease. And because they were young, their caregivers were young. The hours per week, caregivers provided quite a bit of care, an average of 75 hours per week, so a lot of time caregiving. We did have some people who didn't really recognize themselves as caregiving. So for example, a spouse would say, I don't know, I don't really care for him, but they did do the things like cooking and laundry. It's stuff that they see more as their daily life as opposed to caregiving. People had, on average, 3.5 years of living with Alzheimer's disease, and over 75% of the sample lived more than 10 miles away from our center. Bob, any questions that you're aware of or concerns?
I'm not seeing any questions coming up, Allison. I'll just remind everyone if they have questions, they can put them in the Q&A chat box, or if you can't find that, you can respond in the regular chat box and we'll sort it out. I think you're doing fine, Allison. Keep on and running.
Okay, thank you so much. All right. So now I'd like to talk about the feasibility. As those of you who know who work in telemedicine, feasibility is really important to us. We want to know, can people access this? Do they like it? Is it easy for them? So we actually had 33 people with Alzheimer's disease consent to participate in the study, but 5 dropped out. Those that dropped out, only one person dropped out because of technological issues. The rest dropped out because of time and health. Of the 28 dyads that completed the visits, 4 patients, people with Alzheimer's disease, were unable to complete the telemedicine Montreal cognitive assessment. The main reasons for those were dementia related. So they couldn't pay attention enough. One person fell asleep. One person just got really irritable and didn't want to do it. It wasn't because of the technology. All of the caregivers completed both the in-clinic and telemedicine batteries, and this is really important for those of you who do research with caregivers. Oftentimes, we'll do a research study and we'll mail a questionnaire out to a caregiver or family member and ask them to please fill it out and mail it back. As I'm sure you know, return rates on those surveys are notoriously low, and you can send them reminders and call them, but when the data doesn't count until it gets in your hands. And so in our study, we did all of the caregiver assessments via telemedicine, so we had the data right then and there. In general, the mean administration time in the clinic was a little bit long, was 41 minutes, and but telemedicine wasn't that different, 47.5 minutes. Caregivers, for the most part, and again, caregivers seem to appreciate the the telemedicine option. It's just easy. You just get a link and you sign on, and there you are. You don't have to have your care partner change his clothes or get in the car or feed her. You just log on. So you'll see by these quotes that one person said, "I prefer to have the visits as telemedicine and not waste my energy and resources." Another participant, however, felt that our offices were too cluttered, and that was distracting. And because of that, we arranged with our office to get a specified telemedicine suite, which was actually just a closet that we remodeled, and now we have a very quiet place to do the telemedicine visits. And I just see a question coming up on any tips on encouraging caregivers to utilize telemedicine in Alzheimer's care, which is just a marvelous question. What I've learned is that there are lots of opportunities for caregivers to get help and support online. So for example, the Alzheimer's Association has chat rooms, and that's very easy to find. You just go onto the alz.org, and they have chat rooms. There is one study coming up. It's called Telesavvy, and that study is we're looking at the feasibility and the reliability of a caregiver intervention called Savvy Caregiver. Many people in the dementia world have heard of it. This is a nationwide study, and we will be recruiting caregivers probably starting in January. So if you're interested or want to hear more about this study, you can just hook up with Bob's organ at NRTRC and let them know, and they will contact me. We are looking for over 100 caregivers. But I just want to say one more thing about the writer's question. Even though telemedicine is gaining a lot of traction in the world, we still aren't very good at helping caregivers with telemedicine care as far as caregiver support. We're working on increasing access and increasing availability, but most of the caregiver support programs are just that, chat rooms, support groups that are done via typing. We don't have a lot of live one-on-one caregiver support. And I'll talk about that in a minute. Are you aware of any telemedicine-specific training for caregivers in providing this type of care via telemedicine? That's a wonderful question. I don't know of any telemedicine-specific training programs, but that is a fabulous idea. That said, again, the Savvy Caregiver program will be coming out in January, and that program specifically trains caregivers to take care of their care recipients using telemedicine. And in the Savvy Caregiver program, they'll have a video display of each Savvy Caregiver session, and they'll also have a live support group option for them. And then as far as teaching us to help care for caregivers via telemedicine, again, there's very little out there, but again, the Savvy Caregiver will train facilitators. So if anybody's interested, they can certainly contact me, and Bob will help us. We need a lot of people for that study, so I'm hoping you will contact Bob, and he will get in touch with me. Let's see. Thank you for your questions. Keep them coming. So let's talk about reliability. What we found, to our delight, is that the Montreal Cognitive Assessment holds up really nicely on the telemedicine platform. So you'll see here this ICC of 0.93, the interclass correlational coefficient. What that tells us is that we can use the Montreal Cognitive Assessment via telemedicine with confidence. And this is very important because with the projected increase in the number of people with Alzheimer's disease, we need tools to be able to assess via distance. Granted, we did modify the MOCA a little bit by using the visual spatial sections on paper, but for the most part it held up beautifully, and this could easily be adapted for any clinic. the two sections that we did separate out, the visual spatial section, the ICC was fine on that, and then the letter clapping instead of tapping, that held up well as well. The CDR, the Clinical Dementia Rating Scale, that's been around for years. It's out of Washington University. It had a very good score of 0.75. And the RMBPC also held up well with an ICC of 0.77. The one that's really interesting is the Geriatric Depression Scale of 0.61, which is considered good reliability. However, it's not fabulous. You know, we'd rather see it closer to 70 or 80. And the reason for that is because the GDS actually doesn't hold up that well for people with dementia. It's a measure of geriatric depression that's designed for people who are cognitively intact. And what the research tells us is that the reliability goes down as the cognitive impairment goes up. So somebody with a MOCA score of 11 or less, you may not have a very reliable GDS score. So if you'll see here, our average MOCA was 12.2 in clinic and 13 in telemedicine, but our range was 0 to 23 or 0 to 24. So the 0 means that these people with Alzheimer's disease couldn't answer any of the questions on the cognitive assessment. What's really interesting and important about this score, the 0, is even though they couldn't answer any questions on the cognitive assessment, they were still able to engage with us and look in our eyes and talk with us enough so that they didn't get any points. So what this says is that even for people with severe dementia, the MOCA could be used. Let's see. And then these are the caregiver strain questions. Again, the grief scale, the average score was 47, which is moderate amount of grief. When you get closer to these numbers, like the 66, that's more grief, and that's somebody that would need support and guidance, and to name the fact that they're probably grieving, and that they need to understand that this is what grief is like, and it's a normal process. For people who live with a family member with Alzheimer's disease and related dementia, the grief that they experience we call pre-death grief. It's not anticipatory because with Alzheimer's disease, we don't know oftentimes when a person with Alzheimer's disease is going to die. So we can't say, well, they have about 6 months. We can make a good guess. But the changes, as many of you know, is that the Alzheimer's disease changes often occur really early in the disease. So theoretically, a person could live 5 to 10 years with Alzheimer's disease, and we know from the literature that the grieving starts with the diagnosis. So somebody could be grieving for years and years and years and not recognize it. And so it's important that we do recognize it, call it out, and help these people. And we can do that by telemedicine. This measure was designed as a paper and pencil test that caregivers could do on their own. We read them the stems and asked them to respond. And the ICC was very good. It was excellent at 0.87. The Zaret burden interview, of course, assessing burden, came out very nicely as well. And this is only a 4-item measure. The ZBI 4-item has been found to be reliable and valid in the literature, and now we know that we can use it via telemedicine and have reliable results. And then the RMBPC, again, how much do caregivers react to the behaviors? How much do the behaviors bother caregivers? And we can see from our ICC that that came out nicely too. So we can use the RMBPC via telemedicine, and we can trust the results, and we can assess and care for the caregivers using this measure. And here it is just graphically. You'll see on your left is the MOCA score, the correlation. So on the left-hand column, you have your clinic score. On the bottom, you have your telemedicine score, and this beautiful line just shows that they line up very nicely. And again, with the Zaret burden interview, the in-clinic score, and the telemedicine score both line up very well. This one is for the persons with Alzheimer's disease. This is for the caregivers. And these graphics just illustrate how nicely these came out. Oh, I got a question. What are your thoughts on using telehealth tools like sensors or fall detection systems for ADL tracking in homes or senior living facilities in combination with live video assessments? I think that's a great idea. I'll be quite frank. I don't spend a lot of time in the literature looking at sensors or fall detection systems personally. That said, our center, the OHSU Latent Aging and Alzheimer's Disease, does spend a lot of time and energy looking at unobtrusive monitoring, and we can look at patterns of how people move around their homes, and we're able to pick up subtle changes, for example, in gait. I think for the more specific sensors, it could be a very nice combination to do the assessments with live video assessments. I don't know, honestly, I don't know how reliable the live video assessments are, but I imagine that the literature is out there, and I imagine they would be pretty good. Now, I just want to touch on what we're doing now, now that we have completed the phase 1 study. And actually, we've also, when I made the slides that we hadn't quite completed phase 2, but since then we have completed phase 2, where we assess the feasibility of direct-to-home telemedicine clinics, follow-up clinic visits. So when people come to our clinic with dementia for a follow-up visit, we assess their memory using the MOCA. We assess the caregiver strain. We ask caregivers and families about advanced care planning. We ask them about behaviors and depression, and we ask about medications. So we did those same things in phase 2, and we also did our best to comply with the American Academy of Neurology's quality measures for dementia care using telemedicine visits. To the point, to your point about the live video assessments, we had minimal assessments. We would check things like cranial nerve function and, of course, voice and affect, but we didn't do a gait analysis, and we certainly didn't do the hands-on tests such as reflexes and so forth. And so in phase 2, we found that phase 2 was quite feasible. We had about 40 participants, and not all of them, but the majority of them did complete the visits. And we measured feasibility by assessing the number of visits scheduled compared to the number of visits completed. And those turned out to be quite a high number and very good. And if you'd like me to, Bob, I can pull up that slide set later as well. What phase 2 did for us is it demonstrated that we can do telemedicine follow-up visits in our clinic. Now, one of the things that's very interesting, and I know all of you in the telemedicine world understand this, Medicare doesn't pay for direct-to-home telemedicine visits. It only pays for a telemedicine visit if a person lives in an area of a specific designated area that's considered rural. And if that's the case, then the person with dementia and the caregiver have to drive to what's called an originating site. So it could be a hospital or a clinic where they hook up with the clinician. Then Medicare will pay for those visits, but otherwise they won't. So for those of you that work in the dementia world, you can appreciate how unrealistic that is. First of all, for many of our families with dementia, we don't want the person with dementia driving in many situations, not all. And of course, the whole idea of this telemedicine service is to reduce that barrier. So it is very frustrating for us that Medicare doesn't pay for it. That said, I keep hearing through the grapevine that that will change soon. Until then, we, like other hospital systems, are trying to figure out how we can do direct-to-home telemedicine visits and somehow work around the Medicare issue. Here at OHSU, we have certain rules and regulations we have to comply with, and thus we do have to charge people. If they do want to do a telemedicine visit, some families find it is cheaper to do a telemedicine visit than to travel. The average telemedicine visit based on our rules and regulations is about $300, which is out of reach for many families. Yeah, and I think that the important key here is that that telemedicine, you can provide dementia care for anyone with a computer and internet access as long as you don't have to, you have a computer. You don't have to build Medicare. Yeah, the Oregon Telehealth Parity Law requires private payers to reimburse for telehealth care provided in home. Exactly, thank you. Yeah, in Oregon, definitely we can reimburse, we can get reimbursed via private insurance, and actually Medicaid offers direct-to-home telemedicine visits. Most of the people we care for Alzheimer's disease, however, are covered by Medicare, and that's where we run into trouble in our world. The other component that our research helped with is my current study, which is assessing the feasibility of a caregiver support program called STAR-C. Many of you probably know this program. It was developed by Linda Terry in the late 90s. It's used all over the nation in assisted living facilities, VA facilities. Initially, it was designed as staff training for assisted living residences, the STAR, but then they used it in the community as well to train community caregivers. Because the name STAR is so familiar to people, even though it was adapted for in the home, we still call it STAR. And this program focuses on helping caregivers learn about what triggers behavioral symptoms, how to break the chain of events so those triggers don't occur. In nationwide studies, it's found that STAR-C actually does reduce burden and depression in caregivers. What's interesting is it's only used in live, and in STAR-C, the STAR-C trainer drives to the caregiver's home, and it provides 8 lessons over 8 weeks about the behaviors and how to adapt and modify our behaviors to help the persons with Alzheimer's disease. That works if you live in Portland, but it doesn't work very well if your care recipient, for example, is in Burns, or your caregiver lives in remote Oregon or anywhere else really. Those 8 visits are impossible. So what we're testing now is whether we can do STAR-C via telemedicine. And it's to date, we've completed 3 STAR-C visits, and it's just been wonderful. Caregivers just love it. Sometimes you hear things about, well, it's not as personable. I don't get that. These are very personable and touching visits. Caregivers through my previous study and this study often weep and express their emotion. There's a lot of laughing and crying. It's a very intimate experience, and thus far it's proven to be really very exciting. Again, we've only done 3 people, so hopefully we can complete the study. If you are in Oregon or Southwest Washington and you know of a caregiver that might benefit from this, go ahead and let Bob know, and we'll make sure that we get them on the study. And we're hoping to get a larger study funded in the next year or 2 for this. So stay tuned. Okay, so now I'm going to wrap up. Just to reiterate, for phase 1, the scores and the measures were similar across both sites and turned out to be quite reliable. We're going to expect about a 40% increase in the numbers of persons with Alzheimer's in the next 10 years. So this is one tool in our toolkit to help us manage the increasing numbers and the actual decreasing numbers of clinicians. It's important to know that 58% adults of adults over age 65 use the internet, and the 85 and older group is the fastest growing group of users in the United States. In Oregon, let me back up. There have been assessments of how well states are able to get broadband access to across their states. Oregon rates number 3 in adopting broadband services. So it's a wonderful state to do this kind of research in. And then, you know, we all know that many caregivers, even though there are many programs and many books, they don't get the support that they need. And so bringing that directly to them via telemedicine, I think, is a very promising way of reaching out and helping these people. Caregivers for persons with dementia not only experience stress and burden, but their health is also affected by caregiving, increasing their risk for high blood pressure, diabetes, cancer, and even dementia themselves. So it's important that we support the caregivers. And then finally, like I said, we can increase care and research using this system. So I want to thank the Oregon Office of Rural Health and the Oregon Health Authority for helping us develop and fund this study, as well as our own center, which provided a lot of the supplemental funding for carrying out this study. I have another question here before I close up. Do you have a tip for anyone looking to get buy-in from their organization to develop this kind of program in the first steps? That's a wonderful question. Here at OHSU, we're very lucky in that we have a full telehealth department, and that's the first place we went to discuss telehealth. So if you're at a university or another setting where they have a telehealth department, call them first and get their support before you go to your administrator. I think that's very effective because your telehealth department can give you the language that you need to sell your program. So for example, we spoke with Mark Lovegren here at OHSU, who told us about the connectivity, the security, the availability of staff to help us, and from there we could develop a more robust program. Alternatively, if you don't have a telehealth program, it may behoove you to go through a certification program to help develop such. And for example, there is one at UC Davis where it's a 2-year certification program that you do online at your own pace. It doesn't have to be 2 years, just that's how it's paced out. And those courses can be taken electively, so you don't have to take all the courses. So for example, they have one course specifically on telemedicine, and that's through University of California at Davis. Yeah. Oh, and this is great. Bob just chimed in. NTRC has a video toolkit that may help caregivers prepare for telehealth and set up their telehealth suite. Yes, that's perfect. And thank you, Bob, because that's one thing I wanted to point out. One of the things that did make our program successful was the fact that we did have an assistant that helped us connect with all of our care recipients, and she did a lot of hand-holding to help people get the link, set up their computers, get their audio straight. This is Kate right here, and without her, the program would not have been successful. So a lot of information in an hour, but I love the questions, and I can take a couple more questions, or if you'd like, I believe I'm not sure if I have my email on here. Well, Bob can get it to you. Have Bob, the NRTRC.
You're welcome to contact me, and I'll forward anything that you have to Allison, and it's bob@nrtrc.org. And if you have any further questions, we've got about 3 minutes left. While we're waiting to see if we have more questions, Allison, I want to thank you for joining us today and sharing this really interesting and exciting research, and I certainly wish you well as you grow your program in the future.
Thank you so much. I sure appreciate your support.
And I think Blake has a survey that she can give our viewers. I think she can put it up on the screen. This is the second time I've used this platform, so I'm not sure exactly what works and what doesn't, but we'll hope for the best, and we'll invite you to join us next month. If you have any more questions for Blake, we've just got a little bit of time left. Here we go.
Do you have an editorial you can share with me on this study for Telemedicine magazine? Oh yeah, that sounds great. I'd love to. I don't have anything written right now. We've submitted the Act on Phase 1 to the gerontologist for publication, and we're crossing our fingers that they'll get back to us soon. But yeah, you know, Bob, it looks like, can I just type out my email here and people can contact me if they need me?
Absolutely.
EDU, sorry. How's that?
I'm not seeing it yet. Sometimes it takes a minute to show up. I'm not seeing it though, Allison. Let me see if I can.
Oh, here, I can do it down here. I'll do it down here.
I've just put mine up, Allison.
Okay.
I don't know why yours isn't showing up. That's kind of a...
Yeah, the send button is whited out.
Oh.
So I don't know.
That's probably because you're a presenter.
I can talk to you, but you won't let me talk back. That's cute. Well, yeah, simply email Bob and he will forward it to me. That's no problem at all.
And with that, it looks to me like something's happening here. I think Blake is putting up the survey link now.
Okay. And Bob, if you could get me those results, that would be very helpful to us.
Yes, we will certainly share those with you.
Thank you.
And the survey will kick up once the session ends.
Okay, great. Well, thank you everybody for your interest. At this point, I think I'll log off unless there are more questions or concerns.
I think we wore everybody out, Allison.
Okay, thank you so much, Bob. Nice to hear your voice.
You bet. Thanks a lot. I hope to see you in Seattle next year.
Oh, good. Okay. All right. Bye-bye.
Bye.